So I'd like to call Dr. Low to the floor. He will talk about ERAS guidelines and esophagectomy outcomes. We also call him Mr. ERAS because he's very famous for that. I had the opportunity to visit him in Virginia Mason in Seattle with the whole team, where we learned a lot and also adjusted our care path according to what they are doing there. In addition, he's also very known for the ESO-data study, the complication study group, which is well known all over the world today. And many publications have already come forth from that, and care has improved accordingly. So Don, the floor is all yours.
Hello. Now that I'm unmuted, I'll once again thank everyone for including me in this important academic event. I'm going to try to give you some insights into what makes a successful ERAS program with respect to esophageal resection and what are our challenges for the future. If you look at the literature, you have this impression that ERAS has been around for decades. In fact, the concept of ERAS was only introduced in 2005, and the first major publication of a specific enhanced recovery program with respect to colorectal surgery only appeared in 2013. There actually has been a huge amount of groundwork done prior to the initiation of formal ERAS programs with respect to fast track and standardized clinical pathways that really blended in to the ERAS programs we know today. In 2018, I listed the number of specific enhanced recovery programs involving a wide variety of surgeries. I updated it for this talk, and there are currently 18 standard and formalized ERAS Society guidelines involving virtually every aspect of modern day surgery. We all know that ERAS pathways have some standard issues that transcend every ERAS protocol, irrespective of the type of surgery. Things like smoking cessation and DVT prophylaxis is standardized throughout the protocols. But when it comes to the aspect of esophageal resection, and the ERAS Society asked me to be involved in the production of the specific ERAS guidelines, and they have been required to be different than what has been done in several other protocols. Why did they ask me to become involved? Well, I'm never completely sure, but I think it's because I've been involved in the aspect of standardizing standardized clinical pathways for esophagectomy since the early 90s. We've reported our results on several occasions, and in a fairly early era, i.e. the 1990s up to 2011, with a significant number of patients, we clearly documented that even though our patient population was becoming more complex, i.e. older and more comorbidities, that during this exact same period, predating ERAS, we could see significant improvements in blood loss, operative fluid utilization, ICU and hospital stay, and for the very first time, demonstrate that these operations could be done with a mortality rate of under 1%. Now, I'm showing you these 5 slides in a row to give you an idea of how extensive the ERAS guidelines are for esophageal resection. I'm going to allay your fears. I'm not going to talk about all of these because, quite frankly, there's a lot of overlap, and I'm going to try to highlight what I think are important systematic issues within ERAS guidelines, especially with respect to esophagectomy. The non-procedure specific components of ERAS for esophagectomy really are fairly standard. With respect to procedure specific components, there were 2 areas that we felt were more important, and these involved increasing information, as Ed has highlighted, on nutritional intervention and multidisciplinary tumor board and its importance in all patients. With respect to the operative components, however, esophagectomy is the first operation that actually has a thoracic component to the operation. So increased aspects of what we need to do with respect to NG tube and chest tube management, and much more importantly, anesthetic management, pain control, ICU, and double lung ventilation, all for the first time were an important component of these particular guidelines. Tim Batchelor has raised what I think is a really important issue. And the issue really is are the improvements we see in ERAS in all of the areas of surgery that we use it, is it due to an amalgamation of all the ERAS components, or are there specific individual components that can affect outcomes to a greater degree? I think that's an important question, and I think both are true. If you look at this report from ERAS with respect to thoracic surgery, you can see that the one issue that they found most specifically affected morbidity and length of stay with respect to lung cancer patients was the achievement of early mobilization. This is an example of one of our esophagectomy patients, which is 2 hours post-op. This particular individual was operated 10 years ago and had an open Ivor Lewis operation. I'll remind the audience that in 2010 in the United States, 50% of esophagectomies in the United States, and I suspect worldwide, were ventilated at least one night after surgery. For the past 10 years, our mobilization criteria was to have the patient in a chair 4 to 6 hours after the operating room, walking in the hall within 12 hours of leaving the OR, 6 to 8 walks on post-operative day 2, and independent mobility in day 4. So you can see that in a fairly short period of time, you can get from a very bad place to a very good place with respect to the right infrastructure. I have 3 meta-analyses to talk to you about. I'd like to comment on my feeling of doing meta-analysis in the early components of the literature's evolution. But I can tell you in these 3 studies, all of which have come out in the last 2 years, ERAS components were looked at and compared to conventional therapy. And all 3 of these studies have demonstrated that ERAS can unequivocally affect length of stay and pulmonary complications in esophagectomy patients. Other improvements in other areas are less clear from the literature. With respect to individual institutions, this is a publication for diseases of the esophagus in 2015, surprisingly demonstrating that this institution did not see significant changes in morbidity, mortality, or length of stay, but showed that there was an evolution in areas, all of which are a component to ERAS pathways. This very extensive recent review that's come out in Disease of the Esophagus from Leuven compared a large group of transitional care to ERAS pathways and found once again improvements in respiratory complications and median length of stay, but also improvements in other important areas such as overall complications, indicating that the ERAS pathways will have different results in different institutions. So if we were to say what the literature has told us about where the bang for the buck is regarding improvements, I think unequivocally ERAS guidelines can improve respiratory complications and length of stay. There's an increasing body of evidence that suggests that it impacts overall complications and anastomotic leaks. But at the present time, we do not have data on operative mortality and readmissions. Now, what are the important issues? And I'm going to cover some things that Ed has already mentioned because they're close to my heart. If you want your ERAS program to be successful, the engagement of the multidisciplinary team is key. They must want to do ERAS because they want to do it, not because you want to do it. You almost must provide feedback. You can't introduce a program without the ability to assess your results. It's important to know how you're doing. It's also important to give feedback to the multidisciplinary team. This requires audit to be a component of your ERAS program. It's not just the program, it's the monitoring of the results of the program. And as Ed has already indicated, it's important to be innovative. The situation is different institution to institution, and therefore you must adapt your ERAS protocols to what works in your situation. With respect to implementation, no ERAS protocol is going to be successful unless it has strong leadership, which is usually surgical leadership. Having an ERAS nurse coordinator is very helpful and is demonstrated to be have an impact on the outcome of overall results. Engagement of the multidisciplinary team we've already talked about, and audit we've also mentioned. This particular audit was looking at anastomotic approaches, but actually provided some information about 141 esophagectomy units, indicating that fairly recently, less than half of these units have even instituted an ERAS program, and only 22% have an ERAS nurse available. So what makes ERAS successful? Institutional programs should be constantly assessed and modified to improve delivery system and improve and maintain outcomes over time. Now, how do we do this at my institution? Well, here is our ERAS protocol. We've had this in the last 20 years. It's undergone at least 6 or 7 major revisions. I'm going to direct you to the bottom, however, because the bottom is our critical measurable goals. And once again, I'm going to tell you, I'm not going to go through all these, but I'm going to tell you how important assessing these particular outcomes are and knowing how you're doing. Because audit is the only way to assess compliance. It is required to assess the effect of your enhanced recovery program, and it facilitates the feedback, which is key to keeping your team energized. Here's an example from Utrecht, in which they did an audit in 2014 to 16 on 186 patients, and they found that there was a feeding protocol deviation in 59%. They were surprised by this, and I know for a fact they modified how they deal with their feeding protocol and how they deal with their post-esophagectomy patients to improve this, because they knew what their deviation rate was. From the standpoint of NG tube management, there's a strong recommendation within the current ERAS guidelines to remove it on post-operative day 2. We did an audit at my institution in 2015 and found that the mean time that an NG tube was remaining in place was 4.4 days. We met with our multidisciplinary team. We initiated a program of assessing gastric emptying with an upper GI study on post-operative day 2 and looking to remove the NG tube immediately after the study. We weren't looking at the anastomosis. We were looking for quick emptying through a narrow conduit. And if we saw this type of picture, the NG tube came out in the radiology suite. This allowed us to reassess, re-audit in July of 2016, and NG tube removal had gone down from 4.4 to 2.2 days in under a year. We had a plan for how we did this assessment and how we improved. And because we audited, we also had a plan that allowed us to deal with the people with delayed gastric emptying. And this is a study we just completed indicating we're now at 86% compliance, and we now know what to do with delayed gastric emptying. Ed has indicated they don't use epidurals. We don't use them very much either, but we use perivertebral catheters. And when we did use epidurals, we recognized that one of the problems with our immediate post-operative assessments was epidurals are not reliable, which is the reason I think Ed's given them up. When you look at the literature, they'll indicate a defect rate of 17 to 22%. And when we audited our post-operative, immediate post-operative pain management, our defect rate was 18%. We therefore put together our multidisciplinary team. We assessed the aspect of where we were, and we initiated a program of on-table, before the patient leaves an operating room, of an epiduralgram. This allowed us to assess the fact that 40% of our epidural catheters were not ideally placed. And this is an example of an on-table epiduralgram that shows a catheter clearly not in the epidural space. And on the same token, 1 hour later, while the patient was awakened, the catheter was replaced and the catheter is in an optimal place. I'll also tell everyone that we're doing the same process with perivertebral catheters, and we find that our defect rate is now extremely low with respect to this perioperative management. Your next question will be, are these protocols transferable? Well, as Suzanne has said, we've had multiple institutions visit us. One of the first was from the University of Surrey and Sean Preston. He published this data in British Journal of Surgery when he went back after instituting the multidisciplinary program at the University of Surrey. And what he demonstrated that within 1 year of introducing this program, their pre-pathway and non-pathway had shown improvements on day 1 mobilization from 8.3% to 100%. Their complication rate went from 67% to 25%. Their ICU stay went down a day, but their hospital length of stay went down 10 days. And this is just an expression of the fact that these results are transferable. What are the challenges for the future? Well, Ole Lundqvist will tell you that optimizing nutrition, assessing frailty, prehabilitation, and assessing anemia are important next steps for ERAS. My personal feeling is that there's more bang for the buck in assessing how ERAS is affecting quality of life, costs, and survivorship in oncologic surgery. So what are the big issues with respect to initiation and maintenance of an ERAS program? Commitment of the multidisciplinary team is absolutely key. Having institutional resources that allow you to be successful in your individual protocol aspects of things, especially early mobilization, making sure that in the early phases, your programmatic leadership does not turn over. And from my standpoint, the biggest challenge is staff turnover. You can have one dietitian leave your program and it will set back your dietary program for a period of time until you have retraining. So what's the final word? Standardize your protocols, monitor your results. ERAS should not be static, it should evolve over time. If you don't have protocols embedded in your order sets, there will not be consistency. And just as you heard in the talk before, utilize the patient and family as your allies. Let them know what your ERAS goals are, and they will work with you. Thank you very much for this opportunity, and I'm looking forward to fielding questions.
Thank you very much, Don, for your fantastic presentation. There come some questions in through the Q&A. One is for Edward. The question is from Youssef Moulam. He asks about the oral nutrition post-operatively, when you will start with it.
So our oral nutrition start the first thing the next morning, so 30 minutes, but in the recovery, we give them ice lollies just to moisture their mouth, get them coughing and cleaning and the first night. So those are the ice lollies. It's roughly about 30 mils in an ice lolly, but it's slowly enjoy that like a little ice lolly ice cream, if you like.
Thank you. And a question for you, Don. Can you tell us what is your thoughts regarding total minimally invasive versus hybrid esophagectomy in regard to ERAS protocols?
Well, actually, very interestingly, Suzanne, and I think you're in a position to judge this, we have converted almost completely to a minimally invasive approach over the last 3 to 4 years. We're now doing most of our resections totally robotically. We continue to audit our results, and we have seen fractional improvements as we've moved into minimally invasive surgery. Has it been remarkable improvements? Well, our mortality rate is 0.5%, and that's been the situation for 20 years. Our complication rate has been 58%, and it is now 56%. So we've seen some improvements. We don't typically do hybrid resections. What we have identified, however, is our pain management components of our ERAS protocols have changed significantly. I've hinted that we've now gone completely to paravertebral catheters or intercostal blocks. We use epidurals only very occasionally on situations. But the answer to your question is the operative approach will continue to affect outcomes. But interestingly, a well-working ERAS program will be successful irrespective of your approach.
Thank you very much, Don. We have time for one more question. Ed, the early the gastroscopy, do you do it routine or selective at the moment? And what's the indication?
At the moment, I do them quite routinely. If I want to get them home day 4, day 5, day 6, especially if they live very far away, and I need to be confident that they're going to walk out of here without any problems, I do that and take lots of photographs, help teach as well. One of the things I also do during the endoscopy is if I haven't done a pyloroplasty, then I go down and just put a balloon pyloroplasty, a 20 millimeter balloon, just to open out the pylorus, and then do that at the same time as well. So it helps on day 4 or day 5.
Thank you. We have to move on. So Ed, you can introduce the next speaker. For the Q&A, the questions that have already been asked, we will try to answer them. If the speakers can have a look at the Q&A to type the answers so that all questions will be answered. Ed, you can take over.
Thank you very much, Suzanne. And thank you, Don, for your excellent talk once again.